Me. I'm going to talk on diabetes and heart failure, the two sides of the same coin. Diabetes is a coronary artery disease equivalent, and majority of these patients are usually associated with heart failure. Now, we have selected this topic because diabetes is pretty common in the society in general and worldwide is pretty prevalent. And if we see if we see the prevalence of diabetes in Pakistan, around 26.3% of the population, they are diabetic. And out of this, 19.2% are non-diabetic and 7.1% are newly diagnosed diabetic. And there is some variation in the urban and rural population. And the prevalence of prediabetes is again very high, 14.4%. So age greater than 43, family history of diabetes, hypertension, obesity, and dyslipidemia, they are significantly associated risk factors for diabetes. Now the overall type 2 diabetes burden is very high. 36 million people in Pakistan are diabetic. Approximately 2 million are added every year, as cardiovascular disease is the leading cause of morbidity and mortality in patients with type 2 diabetes. And the CV disease contributes up to 49% of the total direct cost of treating type 2 diabetes. Now, heart failure and diabetes, they are closely associated. People with diabetes have 2 to 5-fold higher risk of developing heart failure, and similarly, heart failure is the leading cause of hospitalization. And other way, 30 to 40% of patients with heart failure also have a diabetes, and 2.5 to 4 times higher rate of chronic heart failure in patients with type 2 diabetes compared with those with non-diabetics. Now, diabetes is the risk factor for heart failure development and hospitalization. Comparing heart failure in diabetic and non-diabetic population, so the diabetics are at higher risk of developing both heart failure and heart failure hospitalization. Now, people who have diabetes and cardiovascular disease, they will die 12 years earlier than non-diabetics and those patients who are not in heart failure. And those who are only diabetic, they will die 6 years earlier. Now, this is one of the important slides regarding pathophysiology of diabetes, how that leads to heart failure. So usually in diabetes, there is hyperinsulinemia because of resistance to the insulin, and that usually leads to hypertriglyceridemia, hyperglycemia. And usually these factors ultimately leads to atherosclerotic cardiovascular disease, hypertension, and structural alterations at the cellular level. So these ultimately, by neurohormonal mechanism, ultimately leads to either ischemic cardiomyopathy, hypertensive cardiomyopathy, and or diabetic cardiomyopathy as a cause for heart failure. Now, time to first hospitalization for heart failure is significantly higher in diabetic population than non-diabetic population. Now, this is one of the important slides regarding a consensus report of American Diabetes Association. Stage 1, where these risk factors are there for heart failure. And then these population with these risk factors should go for a biomarkers. And if they are normal, so should be repeated at least once in a year. At stage B, when the structural disorders occur, these population must go for biomarkers, and depending on the reports of biomarker, if elevated, should go for chest X-ray and imaging, particularly like echocardiography, and then to be decided whether had a HFpEF or HFrEF. And stage CD, again, when symptoms of heart failure and signs of heart failure are present, so that will definitely, will again go for imaging and will be decided whether having HFpEF or HFrEF and will be treated accordingly. Now, anti-diabetic therapy in diabetics with heart failure. Now, metformin still has a place in treating diabetes, also in heart failure patients. So comparing this metformin with sulfonylurea, so you can see the cumulative mortality is still significantly less in the patient, diabetic patient with heart failure in metformin group as compared to sulfonylureas. But this is important that the renal function should be adequate. If the eGFR is more than 30 ml, so you can use metformin. And if it goes down than 30 ml, then you have to be conscious and either you have to reduce the dose or stop metformin. Now again, DPP-4 inhibitors, they have a place in diabetic population with heart failure, but in these three studies, only Savor-Timi that have shown that it has got a significant reduction in heart failure hospitalization as compared to other two drugs and two studies. Now, if we talk about heart failure, now SGLT2 inhibitor is the most important part of treatment in the heart failure. And the mechanism of action is that it inhibits proximal tubular glucose reabsorption at the proximal tubular level, and that leads to diuresis, natriuresis, lower blood pressure, and reduced weight. And additionally has a renoprotective effect also. So this is the hemodynamic effect of the SGLT2 inhibitor. But sometimes people ask that if we use SGLT2 inhibitor in non-diabetic population in heart failure, then how it acts. The mechanism in that is a bit different, because the SGLT2 inhibitor will inhibit the reabsorption of glucose when it reaches the serum glucose level, reaches the renal threshold, that is around 180 mg/%. But how it acts in non-diabetic population, so this is very important. Because SGLT2 inhibitor has got a pleiotropic effect also at the cellular level in kidneys, in heart, and in different organs, so it modifies the heart function by its pleiotropic effect. Now in the EMPA-REG trial, I will straightly go to the outcome of that. There was 14% reduction in the three-point MACE, 38% reduction in the cardiovascular death, and 32% reduction in all-cause mortality, and 35% reduction in heart failure hospitalization. Now this is one of the important slide where we can compare the two arms of the EMPEROR study, that is EMPEROR reduced and EMPEROR preserved. So in the EMPEROR reduced, the primary outcome of cardiovascular death and heart failure were significantly less in the EMPA group as compared to the placebo, and similarly the results were sustained in 40th day of randomization. And the slope of decline in glomerular filtration rate was significant. I mean, it has got a renoprotective effect also. And the NYHA classification was, it was improved. And similarly in EMPEROR preserved, again, in the EMPA group, the cardiovascular death and heart failure hospitalization was significantly less as compared to the placebo. And the secondary endpoints of slope of decline in glomerular filtration rate over time were reduced. And NYHA class improvement was there. So is benefit of empagliflozin specific or a class effect? So you can see that SGLT2 inhibitor versus other diabetic drugs, improved outcome with SGLT2 inhibitor is as a class, is not an individual drug. So 40% reduction in hospitalization for heart failure, 50% relative risk reduction in mortality from all cause, and result unchanged with removal of diabetic drugs that increase the risk for hospitalization for heart failure. And the results were consistent. Again, canagliflozin, one of the group of SGLT2 inhibitor, had got a beneficial effect, again comparing with the placebo. And same with the dapagliflozin. GLP-1 receptor agonist, that is the liraglutide. In the LEADER trial, it does not show significant benefit mortality in cardiovascular patients. But now it has shown that cardiometabolic effects are there, but there is a lack of heart failure benefit. Now these are the ESC guidelines and of 2021, where AC inhibitors class 1A, beta blockers class 1A, MRA class 1A, DAPA and EMPA, they are class 1A, sacubitril valsartan as a replacement for AC inhibitors and ARBs are 1B. Now coming to paradigm heart failure, where the dysglycemia patients in heart failure, this is the post hoc analysis of the paradigm heart failure, where the diagnosed diabetics were 36%, undiagnosed 13%, and pre-diabetes 25%. And you can see that in diabetic population with heart failure, the ARNI showed significant mortality benefit both for heart failure, hospitalization, and events as compared to enalapril. And similarly, the insulin initiation was late in the group who were on ARNI. And similarly, the outcome primary endpoint was significantly better in the ARNI group. And again, renal protection were significantly better in the ARNI group. Now these are the studies comparing HFrEF and HFpEF. You can see the drug used on the left side of the slide, and in HFrEF, all the trials, they have shown beneficial effect of all these drugs comparing with the HFpEF, where there is no significant evidence of clinical efficacy of all these drugs in these trials in HFpEF, except SGLT2 inhibitor. Now, what are the recommendations? Individuals with diabetes and heart failure should receive the same heart failure therapies as those identified in the evidence-based Canadian Cardiovascular Society heart failure recommendations. Unless contraindicated, metformin may be used in people with type 2 diabetes and heart failure and should be temporarily withheld if renal function acutely worsens, and should be discontinued if renal function significantly and chronically worsens. For people with NYHA class 1 to 4, exposure to the DAON should be avoided, and beta blockers should be prescribed when indicated for heart failure with reduced ejection fraction, as they provide similar benefits in people with or without diabetes. In adults with type 2 diabetes with clinical cardiovascular disease in whom glycemic targets are not achieved with the existing anti-diabetic medications and with an EGFR more than 30, so SGLT2 inhibitor has demonstrated heart failure reduction in hospitalization for heart failure, and may be added to reduce the risk of heart failure hospitalization. Now, in people with diabetes and heart failure, with an EGFR less than 60, or if combined RAS blockade is employed. So inhibition of RAS is recommended to reduce morbidity and mortality for patients with HFrEF. ARNI/KC inhibitor or ARBs are recommended as first-line therapy in patients with chronic symptoms, chronic symptomatic HFrEF. Treatment with ARNI instead of an AC inhibitor provides high economic value. So starting dose of AC inhibitors or ARBs should be halved. Serum electrolyte and creatinine, blood pressure and body weight, as well as heart failure symptoms and signs should be monitored within 7 to 10 days of any initiation or titration of therapy. Dose of titration should be more gradual with monitoring blood pressure, serum potassium, and creatinine. Thank you very much for listening.